focus of Dr. Nickolas' lab is to redefine our understanding of an approach to bone disease in adults and children with kidney failure. His lab uses advanced and novel methods to phenotype bone disorders in patients with kidney failure and after kidney transplantation, including high-resolution in vivo bone imaging, bone biopsy, cell culture, and transcriptomics, among other things. He also conducts clinical trials to test the efficacy of therapeutic approaches to protect the skeleton from the effects of kidney disease. He is currently PI of 6 NIH grants, and I'm lucky enough to be co-PI with him on a new project. So I can tell you that working with Tom is an absolute joy. He's 100% engaged and just indispensable to his collaborators. So I'm really happy to welcome you here on behalf of the UCSF Core Center for Musculoskeletal Biology and Medicine to share your work with us. Thanks.
Thank you very much for that very, very, very kind introduction. So it's an honor to be here. I'm so happy to be seeing so many people who I know over the past day. And we're going to talk today about, although it's called as visualizing the skeletal effects of CKD, this is really like a biomarker talk. And I'm going to talk about the work that we've been doing to try and develop non-invasive biomarkers to tell us or to visualize what the kidney is doing to your skeleton. So our goals today are learn about bone disease and fractures in CKD patients, gain an understanding of how bone imaging can enhance our knowledge of skeletal effects of kidney diseases, and then help us all appreciate the need for a non-invasive biomarker for bone disease management in CKD patients. So here's our outline. We'll review some definitions in epidemiology. We'll talk about current clinical standard practice patterns for bone disease management for CKD patients. We'll review some imaging methods and their potential as biomarkers. We'll talk about DEXA, and then, of course, DEXA enhancements like TBS and hip structural analysis, all the work that's been done in nature, or a snapshot of the work that's been done in nature, PQCT, PET imaging, and then we'll go into more dynamic markers, so like omics, and what's been going on in that field for biomarker development, and then, of course, what are our future directions. So the biomarker development process is, as we know, a very long and drawn-out process, typically divided into 3 phases: identification, validation, and clinical use phases. In the first identification phase, we have discovery of the biomarker. Then we demonstrate that there are differential expression patterns between the disease and non-disease. Then we qualify that biomarker and we learn more about its sensitivity. Then we take it to this validation phase where we talk about or do studies for sensitivity and specificity. If we're looking at panels of biomarkers, then we pull from those verification studies those biomarkers which perform the best, and then we take those to validation studies where these are longer-term prospective studies looking at clinical outcomes who demonstrated their clinical utility. And then, of course, finally, we can implement these tests in the clinic. This is a very long process, probably like about 10 years worth of work. And what we've been doing in my group is, I feel like this is my soapbox, the treatment gap that we have for bone disease in patients with CKD. And I really want to develop biomarkers that can hasten our ability to treat our patients and close this gap. And I'm going to relate this to what happens in the osteoporosis world, where we have this big treatment gap that we always talk about and we always lament about. But I can tell you that this treatment gap failure that we have for osteoporosis is actually a success when it comes to a comparison with CKD patients. So if you think about the osteoporosis world, you have 34 million Americans at risk, 10 million Americans with a diagnosis, 2.7 million Americans treated. That sounds awful, but I can tell you it's better than what happens in CKD, where we have a disease that's highly co-prevalent with CKD. It's not screened, and when it is screened and detected, we don't even bother to treat it. And this, to me, truly is a failure of healthcare delivery. How common is this in CKD? It's very common. So we know from looking at administrative healthcare data sets or from large-scale population-based studies like NHANES, that when you look at patients with CKD and compare it to non-CKD patients, that the co-prevalence of osteoporosis is 2-fold higher in our CKD patients. And we also know that when you take a look at patients with a pre-existing diagnosis of osteoporosis, so if you that more than 80% of women, more than half of men, 60 years of age or older, have a GFR less than 35, so that's severe CKD. So we know that these two disorders occur commonly together, and whether you're a nephrologist, rheumatologist, endocrinologist, you're going to see these patients in your clinic. So it's really important that we have biomarkers that can be useful, that help you not just to diagnose the disorder, but also to monitor it over time. And if those coprevalence rates don't worry you, then the rates of fracture that occur in CKD patients should worry you. So when we look at administrative healthcare data sets, such as from CMS, and we compare patients in the general population who have normal kidney function to those with kidney disease across the CKD stages, we see that across the life course, fracture rates are higher. We see that if you're a young person, less than 45 years of age, that your fracture rates are equivalent to those of someone in their 70s. And we also see that fracture rates increase in proportion to CKD severity. And not just are these fracture rates higher, but clinical outcomes after fracture are also worse. So also using administrative healthcare data sets from the US, we know that when you compare mortality rates after fracture, and this represents hip fracture, that mortality rates go up in relationship to your degree of kidney dysfunction. And in fact, they're about 2.5 times higher in comparison to in patients who are not on dialysis in comparison to healthy kidney patients. And if you're on dialysis, your rates of death after a hip fracture go up by almost 4-fold. And then not surprisingly, costs also increase that are also go in parallel with your degree of kidney dysfunction. So this truly needs our attention, I believe, and we truly want to develop something that can help the clinician better identify these patients for treatment. So when we think about biomarker development, we're trying to understand what's the underlying pathogenesis, and does the biomarker actually clue us into what's happening? Because not only do you want to detect what the risk is, but if you can also have a biomarker that tells you what is causing that risk, then maybe you have something that you can target with the treatment. So we talk about bone strength being the composite of bone quantity and quality, and I can just tell you that CKD patients have across the board poor bone strength due to global disorders in bone strength. So you look at their bone quantity, they have defects in cortical bone due to the underlying metabolic abnormalities that occur in kidney failure. They have defects in their trabecular bone due to the fact that many of them are older. They're inflamed because CKD is an inflammatory disease. Many are on medications like steroids, which negatively impact trabecular bone. And then in addition, they have disorders in bone quality, including turnover, microarchitecture, mineralization, collagen content, matrix content, and structure. And on the HR level, we have shown that when you take patients with CKD, in particular with fracture, such as with this particular patient of whose tibia we imaged here, and compare that to a patient with normal kidney function and no fractures, that the CKD bone has an immense cortical bone defect. Not just here in terms of the bone microarchitecture, but also we have to remember that in kidney dysfunction, there's bone cell dysfunction. And there's something about the effects of uremia on the skeleton that cause abnormalities in both osteoblast and osteoclast cell function, where they have disorders in bone turnover, where turnover can be either absent completely, normal or high, and then they have defects in bone mineralization, where they just don't lay down the hydroxyapatite well, they don't lay down mineral into the bone very well, they don't produce protein very well, and you can have mineralization that is completely absent, low, or even elevated. And then, of course, the defects in bone volume, where, as we can measure by DEXA or by HRPQCT, where they have defects in cortical and trabecular bone volume. And this TMV system has replaced our old thinking about renal osteodystrophy in terms of specific histopathological entities in order to help the community be less afraid of this disorder. I don't know if it's worked very well when I think about what's happened over the past 20 years since we moved to this system. However, it does, in my opinion, help us better understand the underlying pathogenesis. So as we go through this talk and we talk about the different ways that we can utilize imaging modalities and omic techniques to develop a biomarker approach to defining what's happening to their skeleton, our goal has been to have this holistic approach to biomarker development and bone management, where we don't think about the CKD skeleton as either just renal osteodystrophy or just high turnover or low turnover bone, since that's just one component of bone quality. And we don't think of it in terms of just having low bone mineral density by a T-score, since that's just another singular component of bone fragility. But we think of this in terms of what are the underlying abnormalities in CKD and MBD? So meaning what's the parathyroid hormone, what's the vitamin D level, how does that affect bone cell function? And then on the microstructural level, on the structural level, what's going on with their bone density, what's going on with their microarchitecture, and using that information to help inform us about optimizing treatment. Are we focusing on just the parathyroid hormone, or do we manage both the parathyroid hormone plus the microarchitecture or the microstructural features at the same time? So an optimal biomarker here, or it could be a combination of biomarkers, not just one, would be, does this assess fracture risk? Does this test assess bone dynamics or bone cell function? Does this inform treatment? And then can we use this to monitor treatment? So let's talk then about what we do currently in the clinic and what are the failures of these, what are the pluses and minuses of our current approaches. The current gold standard is bone biopsy with tetracycline double label. So we take a piece of bone from the iliac crest, and through the use of tetracycline, we can get really great information on bone dynamics. We can get information on bone turnover, bone resorption, mineralization. With two-dimensional histomorphometry, we can get information on trabecular microarchitecture, cortical microstructure architecture, and then with staining, we can get information on cell function. So as demonstrated here by this nice big juicy osteoclast that's resorbing a piece of trabecula. However, bone biopsy, as great as it is to inform us on the kind of bone disease present, it's not really practical. It's expensive. You can use it for diagnosis and maybe to inform treatment, but you can't really use it to monitor treatment. I mean, I can't see doing serial bone biopsies over a period of 5 years while treating somebody for their bone disease, getting a bone biopsy every year. That would be really ridiculous. Patients won't do it. It takes about 3 months to do, because you have a month for the labeling, then you have another like 8, 9, 10 weeks to get the results back. So you're really waiting for a long time. So it's not really practical. But this is our gold standard. Our clinical standard are bone turnover markers. And once again, these can be very helpful for us to understand what the bone turnover is, or the renal osteodystrophy type. And this could inform treatment. Doesn't predict fractures in CKD, but we don't know yet. Doesn't really give us any information about other aspects of bone quality, like microarchitecture. But it's useful to help us understand bone turnover and bone remodeling. The AUCs, or the discrimination potential for bone turnover markers, are pretty good for understanding, what the bone turnover is, and they're in the range of about 0.8. Unfortunately, though, these can be limited because although in large studies, they work very well to help us understand what the bone turnover is in determining high turnover from non-high turnover or low turnover from non-low turnover. On the individual patient level, they can be problematic. And they have high negative predictive values for differentiating the different types of bone turnover, but their positive predictive values are very low, less than 50%. So when we think about the current clinical standard, we do have 2 tests that that can be used, but there are limitations, and they're not greatly informative in terms of how we treat patients, in particular how we monitor them. So we've been working on bone imaging methods as a potential biomarker. And DEXA, of course, is the obvious one, since it's very clinically available. And how useful can DEXA be to help us with biomarker development? And DEXA in CKD patients does help us understand fracture risk. So it meets that criteria. And we know this from several community-based cohorts that have come to publication over the past decade, where they've enrolled patients with CKD and non-CKD. They've evaluated the utility of DEXA for fracture prediction. They use World Health Organization T-scores in their analyses, and they demonstrated that DEXA works equally well in patients with CKD compared to without CKD, and that the World Health Organization T-scores also operate as well as they do in CKD patients. DEXA, however, doesn't predict turnover. And we know from studies that have obtained bone biopsies in patients with CKD across a range of turnover abnormalities. And when you stratify those patients and you evaluate their DEXA Z-scores or T-scores, there's no relationship. So that's one limitation to DEXA. How about alternatives to DEXA? Or methodologies that are based on the DEXA, such as TBS. So TBS, we know it's a marker of trabecular microarchitecture. We know that it is operational to predict fracture in patients who have T-scores greater than minus 2.5. But how does this operate in patients with CKD? So we've done some work in this area. We've evaluated and validated the TBS measurements in patients with CKD against transiliac crest bone biopsies. And we've shown that TBS is correlated with bone biopsy-based BV over TV and trabecular width, even after adjustment for femoral neck Z-score. We've also shown in cohorts of patients that are undergoing kidney transplantation, that have a mix of men and women, mean age 50 years, who have T-scores in really a non-concerning range, so normal T-scores, that when you evaluate microarchitecture based on HRPQCT, for those patients who have femoral neck T-scores greater than minus 2.5, but with a TBS score that puts them at increased fracture risk, and for CKD patients, that's been determined to be about 1.37, that when you evaluate what their microarchitecture is, that by HRPQCT at the radius and the tibia, that they have defects in cortical bone, so they have cortical thinning. They have defects in trabecular microarchitecture at the radius, and then at the tibia, they have more defects in cortical bone. And then when you evaluate what happens to microarchitecture after transplantation, we have found that as TBS changes, there's a direct relationship between changes in microarchitecture at the radius and tibia. So for every 10% increase in TBS score, there was a 10% improvement in tibia failure load. What does this mean, though, in terms of fracture prediction? So there are limited studies using TBS as a tool to predict fracture in CKD patients, and the data is kind of iffy. So what's been found in small studies were questionable results, and then in the meta-analysis, in pre-dialysis CKD patients, they found that in unadjusted models, that TBS was predictive for incident fractures, but then once the TBS score was adjusted for fracs or for bone mineral density, that predictive ability went away. For patients on dialysis, we don't really have great data. There aren't prospective studies. In a cross-sectional study, they've shown that TBS did discriminate fractures in dialysis-dependent CKD patients. So I'm not necessarily in favor of TBS as an independent predictor of bone quality in CKD patients. I don't really consider this to be a good biomarker. Definitely not better than DEXA, it seems. Although it did seem that in some biopsy work that compared TBS to a distal biopsy site, that TBS did associate with trabecular microarchitecture. I think more work needs to be done in this arena, but it's just not ready to go yet. I'm actually more interested in DEXA hip structural analysis. And I think that this is an interesting tool because it does give us some information about cortical bone. And if CKD is a disease of the cortex, then maybe HSA will tell us something about it, since it can give us femoral neck buckling ratio. And maybe that's going to be more helpful for predicting a fracture or as a biomarker of bone strength in CKD. What data do we have? So there's been one cross-sectional study that evaluated patients on dialysis, here in green, against healthy community controls, here in blue. And they found that the CKD patients basically had worse cortical bone structure. So they had femoral neck buckling ratio in men and women. They had femoral neck buckling ratios that were greater, and they had femoral neck cortical thickness that was lower in comparison to the community. And if you look at the age categories here, where you have patients going from age 20 up to age 80, you can see that the CKD patients across the board, even the younger patients, had cortical bone characteristics that were worse than the 80-year-olds. So once again, this phenotype demonstrating that there is this early accelerated bone aging occurring in CKD patients. Now, this study was small, only about 226 patients, and they had 65 fractures. They were able to do a cross-sectional analysis, and they found that the HSA parameters were predictive for vertebral fractures. We have no prospective data. So I think that as a biomarker of the bone effects of CKD, that this could be an interesting tool. It's easy to apply in the clinic since it's part of DEXA. But once again, we need prospective information. We also have information on the use of HSA to monitor treatment of therapies. And we do know that HSA can detect improvements in cortical bone quality after treatments like denosumab. So this study comes from a 5-year study in dialysis patients where they evaluated HSA, and they found that over the 5-year time period, those patients who received denosumab had improvements in cortical volumetric BMD, in cortical thickness, and also in trabecular volumetric BMD, and that translated into an improvement in section modulus. So when we think about DEXA-based imaging as a biomarker for the skeletal effects of CKD, it does check off a few of these boxes. So we can definitely use it to assess fracture risk. It seems that we can definitely use it to monitor treatment, but it's not good for dynamics. And because of that, it doesn't help us at all with informing treatment choices. So then moving along, how about HRPQCT? And I actually think that this has, I think, the most promise in terms of being a biomarker for the skeletal effects of CKD, not just for the imaging for the microstructural component of bone quality, but also from the work that Gladia is doing, also probably on the dynamics too. And I'll talk a little bit about that in a second. But HRPQC, I'm very robust on it. You know, great resolution. You can separate out the cortical and the trabecular bone. Tell us about cortical and trabecular microarchitecture. And we know that HRPQCT can tell us things about bone and CKD and even detect this early aging phenotype. So this data comes from Igor Siemens' group, where they had a cohort of patients with CKD, here in yellow, in comparison to a cohort of community patients with healthy kidney function, here in green. They divided the cohort up by T-scores, so normal, osteopenia, and osteoporosis. And as you can see, at every level of bone mineral density, there was worse microarchitecture in the CKD patients. So they had higher cortical porosity, decreased trabecular number, increased trabecular separation, thinner cortices, and of course, weaker bone. So I think it gives a lot of information on what the quality of that bone is. And also, in particular, what's going on with, I think, the main compartment that we're worried about in the CKD and the cortical bone. And we've done work looking at HRPQCT as a biomarker of abnormal cortical bone and also how it relates to fracture. So in one of our studies, we enrolled patients who were healthy kidney controls, CKD patients without fracture, and then CKD patients with prevalent fracture. And we found that the bone compartment that had the highest relationship to prevalent fracture was the cortical bone, and the cortical bone thickness had the best AUC for fracture discrimination of about 0.78. And serial HRPQCT, now this isn't time-lapse, which is what Gladia is doing, but this is just serial HRPQCT, has helped us understand over time what is the area of bone that we're most concerned about. So what is the area of bone that basically is going to be lost the most? And in this study, we evaluated patients over a period of about 1.5 years. And we found that in that time period, it was the cortical bone compartment that was at most risk for deterioration. And these patients had loss of both cortical density, they had thinning cortices, and they had increases in cortical porosity. And interestingly, the trabecular bone compartment was basically stable, untouched. And then feeding off that work, we evaluated in a kidney transplant population what was occurring over the first year of kidney transplantation when there are tremendous metabolic shifts that historically have been associated with bone loss in this group of patients. And through image registration, we basically found that the cortical compartment was the compartment that experienced the most negative changes with increases in cortical porosity over that time period. And those were highly related to the metabolic abnormalities that were occurring due to renal failure, such as the persistence of hyperparathyroidism and how that related to increased remodeling rates in the skeleton. So HR can give us really great information about what is going on with the microarchitecture. How about the dynamics? So there have been some work looking at single time point HRPQCT as a tool to assess turnover type. So one published paper that was a biopsy cohort from the UK evaluated whether or not HRPQCT parameters could discriminate turnover status, so low from non-low turnover. And they found significant discrimination for radius, total volumetric BMD, and cortical volume. And they found that patients that had low turnover had higher volumetric BMD and higher cortical bone volume. In our cohorts of patients, with biopsies and HRPQCT, we tried to repeat this analysis. We found that there were significant discrimination for tibiocortical area and tibiocortical thickness and bone turnover. However, the patients had lower thickness and lower area. So completely the opposite results. So I don't think that HRPQCT, single time point HRPQCT, can give you any of this information. However, the time-lapse protocol that Galadia is now studying, I think, is very, very promising, where you obtain a baseline HR image, 2 months later, a follow-up image, and then based on the differential changes that you see in the bone microarchitecture, then you can derive a bone remodeling score. And based on the preliminary data, I think this looks really, really promising. And hopefully, as we proceed with the study, this will really help us have a single test where we can look at bone quality as look at a biomarker of renal failure or skeletal effects of CKD, help inform treatment choices, and then monitor over time. And the nice thing about this is that I mentioned before, it takes about 3 to 4 months for a bone biopsy to give you information. So this gives it to you in 2 months. So it really falls within a clinically helpful time period. I think it could be very promising. So in terms of HRPQCT, it can give you fracture risk assessment. It can inform treatment. It can give you treatment monitoring. And I think it can give you dynamics too. So this may be like the single biomarker that we can develop. Okay, so how about PET imaging? So there was one study 30, 40 years ago that evaluated PET imaging as a biomarker for bone turnover in dialysis patients. It was in, I want to say 10 patients. The correlation coefficient was about 0.95. In that era, it took about 3 or 4 hours to get the imaging done. Very, very high radiation to the patients. No one was interested in ever repeating that study. The patients had no interest in ever doing a PET scan. And these are dialysis patients. So you got to figure they're in the dialysis unit 3 times a week, 4 hours a session. That's a lot of life lost. And they have no desire to come back in for long imaging studies. Improvements in PET imaging technology in combination with CT have been able to give you faster image acquisition time in the range of like 5 minutes if you're focusing on one area of the skeleton. With the addition of CT, you can get bone volume, and you can separate out cortical and trabecular bone. The current radiation dose is much lower in the past. It's higher than HRPQCT, but it's much lower than what it was in the past. And there's been a resurgence now in the utility of PET imaging to help us understand TMV status, so turnover mineralization volume status. And now there are 2 studies evaluating whether or not this is a feasible test for us to use in the clinic. So, and this was the first study that was reproduced, or that was repeated from the original, that came out about maybe 2 years ago. And it was a small study. They only had 15 biopsies, but they had a range of turnover. They had 6 patients with low turnover, 3 with normal, 6 with high turnover. They had, in terms of bone volume, they had mostly low bone volume. Some patients had, well, 2 patients, so 1 patient had normal and 1 patient had high, but everybody else low. And there was no mineralization defects, which is pretty consistent with the current era of renal osteodystrophy, where nephrologists are much better at supplementing with vitamin D and calcium, and mineralization defects today are actually very, very rare. So what did they find? So when they did the discrimination analysis, they compared PET-CT with PTH and with osteocalcin as markers of turnover. They found that for differentiating low from non-low turnover, that PET-CT did have the highest AUC, but for discriminating high from non-high turnover, PET-CT fell somewhere between osteocalcin and PTH. But there were some limitations. So first of all, none of these were significantly different from each other. So really they all operated the same. When you combine PET-CT with a circulating bone biomarker, there was no improvement in the AUC. In terms of differentiating mineralization defects, there was no heterogeneity in the cohort because nobody had any mineral defects. As easy as this procedure is to do in comparison to the past, it still requires that patients get injections and then get blood drawn over a time period for the rate constant. There is more radiation exposure than what we would like, so there's more than HRPQCT, and if you're focusing on protein biomarkers, there's 0 radiation exposure there. And once again, this was a single study. So I think PET-CT is an interesting tool, although I don't really see uptake happening very easily in the kidney world, because the patients are still not going to want to come in for imaging tests that require them to get injections and blood draws. But I think it could be potentially interesting because it is a single test that can give information on TMV status. So for PET-CT, we don't have any information on fracture risk assessment. It can give us dynamics, and we still don't know yet whether it can inform treatment or even be used for treatment monitoring. So then finally, let's talk about omics. And I think that omics is a fascinating world to work in, where we can get information on transcriptomic control of what's happening to bone cell function. And it may be that the best biomarker that we can get for visualizing the skeletal effects of CKD is a combination of an imaging tool such as HRPQCT with a dynamic biomarker like protein biomarkers or microRNA biomarkers. So we've been working in the microRNA field, and we have a project ongoing where we're assessing and validating the utility of microRNAs to be a biomarker for bone health and CKD. So what are they? These are small non-coding nucleotide sequences produced in the nucleus that get processed and then incorporated into an RNA silencing complex, and they negatively regulate messenger RNA function. Then they can be secreted, and they can have distal effects far away from the cells in which they were produced. In the bone world, there have been a number of microRNAs that have been identified that control various aspects of bone quality. And for a desirable CKD biomarker, we would want the microRNAs to assess bone quality, reflect what's happening at the bone cellular level. We would want to see that there's a change in these biomarkers with changes in tissue level quality. So in other words, if you're using it to tell you what the underlying bone quality is in the beginning, so what's the bone turnover in the beginning, and then you give somebody an anti-resorptive, you want it to change in response to that drug to help you monitor treatment. And then you also want this to reflect what's going on in the appropriate bone compartment. And in CKD, we're mostly concerned with the cortical bone compartment. So we want to make sure that the microRNA has information regarding cortical rather than trabecular bone. I'm sorry that this slide is so confusing, but we currently have an R01 where we're looking at those characteristics of the microRNAs, and this is between myself and the Indiana Bone Group. And what we did for our pilot data was we took one of our biobank cohorts of bone biopsies, and we stratified the cohort based on cortical bone turnover rather than trabecular bone turnover. And we wanted to really compare low versus non-low bone turnover, because that's where we think the money is, because if you're focusing on, let's say, on treatments, you really want to make sure that you're not giving a patient with low bone turnover an anti-resorptive. Whether they have normal bone turnover or high bone turnover, you can give them an anti-resorptive and be fine, but not a low turnover patient. What we found was kind of intriguing. We found that in terms of the typical biomarkers that we use, so in terms of PTH, bone alkaline phosphatase, osteocalcin, CTX, P1NP, TRAP, we found that those biomarkers didn't differ between the cohorts. But we found that 4 microRNAs were significantly lower in the low turnover group. So then we did some other analyses, and we then re-stratified the group according to bone turnover in the various bone compartments. So we looked in the trabecular compartment, the endocortical compartment, and the intracortical compartment. So trabecular, endocortical, intracortical. And we found differences in how these biomarkers performed in each compartment. So for the trabecular compartment, we found that PTH and BSAP and CTX discriminated low from non-low, but none of the biomarkers did. None of the microRNAs did. In the endocortical compartment, we found that really it was only the panel of biomarkers, the panel of microRNAs that discriminated. None of the regular protein biomarkers and none of the individual microRNAs discriminated. And then in the cortical compartment, the typical biomarkers had no discrimination, but the microRNAs discriminated low from non-low, and the combination of the microRNAs together had an AUC of about 0.95. So very, very high discrimination for just the microRNAs. Then in a rat model of CKD, we evaluated bone tissue expression of the microRNAs. So we took a group of rats that had just CKD and hyperparathyroidism, and that would be a marker of high bone turnover, okay? And these rats expressed high levels of the microRNAs. We then suppressed bone turnover with both calcium and zoledronate, and those would be our models of low bone turnover. And in those models of low bone turnover, there were significant decreases or significantly lower expression of the microRNAs. So this led us into this pathway where we developed a grant around this, where we proposed that microRNAs may be better biomarkers of turnover than protein biomarkers. And we currently have a very nice study where we're looking at a cross-sectional cohort of about 100 patients across the spectrum of bone turnover, equally divided between low, normal, and high. We'll be doing microRNA-seq in this cohort, validating our work and trying to identify other microRNA biomarkers of turnover. And then we have a prospective cohort where we have CKD patients who are being managed for their bone disease, for the osteoporosis with either anabolic or anti-resorptives. And we're doing quad-label biopsies, and we're seeing how the biomarkers change in response to changes in treatment-induced bone turnover. And then at the quad biopsy, we're also getting a second bone core where we'll be doing tissue level work in the humans, assessing what the microRNA expression is in the bone itself. So this will have a correlate between what's happening in the skeleton or in the bone tissue and in circulation. So we think that this is a very nice project to help us develop a better biomarker. And these patients are all undergoing HRP-QCT, and we're going to also have bone quality. So we'll also relate the microRNA to what's occurring with trabecular and cortical microstructure. Along those same lines, we're also working in cell culture. So what we've done here is taking, once again, along this microRNA work, is we're trying to determine, so what do these microRNAs do? So typically they silence gene production. So what we're doing now is we have a cohort of patients, a small cohort, where we have 5 patients with low turnover, 5 with high turnover. We get 2 bone cores at the biopsy. And these are untreated patients, just all comers. And we do 1 core for histomorphometry and 1 core for osteoblast cell culture. And what we're doing is we're taking the microRNAs that we've identified that correspond to these turnover types and assessing how they affect osteoblast function and maturation. And what we found so far in the culture are that we've identified a few other microRNAs that we didn't identify in our pilot work. And these are the 2 that we found that are expressed differentially between the patients with high versus low bone turnover. And we've also found that they're expressed both in the bone and, or in the cell culture and in circulation. And we'll be adding these to our mix to assess what's happening with bone cell function. And then finally, in terms of where we're going in the future, we're currently in the middle of a very interesting project where we're looking at complete transcriptomics in CKD bone. And our goal here is not just to develop a biomarker, but is to help us understand what's driving CKD bone, what's driving renal osteodystrophy. In particular, in early CKD, we know that in early CKD, the skeleton is affected. There are turnover abnormalities that occur even when your GFR seems normal, but yet you have a kidney problem. And we don't know why that happens. So we have this very nice project where we have performed bone biopsies across the CKD spectrum. So from CKD stages 2 down to dialysis, we're fully recruited now. And we are getting, of course, two bone cores. And the second core that we get goes for all kinds of beautiful transcriptomic analysis, ATAC sequencing, single nuclear analysis. And right now, we're just going through all of this data, and we're relating it to the histomorphometry. And we're finding that there's very interesting signals that are occurring in CKD bone across the spectrum. Like, for instance, we all know, I guess, Sundeep's work where he's found that there, in osteoporosis, there are senescent signals that are occurring. What we're finding is that in CKD bone, we're seeing senescence maybe occurring in early CKD, but in late CKD, none. It's all apoptosis in late CKD. We don't really know why that's happening. We think maybe it's because of very, very high levels of PTH occurring in dialysis patients, or maybe other things. But it's fascinating to know that this project may actually clue us into what are the underlying drivers of renal osteodystrophy, and then are any of these druggable? And can these be used as biomarkers of the disease? So to conclude, what are our future directions? So I'm going to go back to this biomarker development process. It's a long and arduous process. And CKD, we're way, way, way behind the osteoporosis world. And whereas in the osteoporosis world, they're at this phase of clinical diagnostics where they have effective tools, effective treatments that have decreased fracture rates for the general population. For the CKD world, we're still here. And we're still identifying, we're still discovering, we're still developing new biomarkers. We're still in validation phases and verification phases. And hopefully, I'm hoping that in the next 10 years, that we can advance to a place somewhere near what's going on for the osteoporosis world. So to summary and conclude, so bone disease and fractures, I think, are a real serious problem for our CKD patients. And part of this treatment gap, part of this problem, is that we don't really have the biomarkers there to tell us what's going on. We don't have easy diagnostics and easy treatment monitoring tools. The therapeutic arena for CKD bone disease is another problem, but I think that we're going to get to a better point in the near future. And it may be that the best biomarker is not a single biomarker. It may be that the best biomarker is a combination of imaging plus a circulating biomarker, but I do feel that in the next couple of years, we're going to find out that information, and we may have some great news for the nephrology community for managing this disorder. So I want to thank the many collaborators for all of the work that we've been doing in this field, and I want to thank you all for your attention.
Thank you so much. I just want to tell everybody online that you can go ahead and unmute if you have a question. And do we have any questions here in the room?
Hi, I'm here on Zoom. I don't know if you can hear me in there.
Yes, we can.
Okay, great talk. This is Tamara Alliston, and I was wondering if you know where those microRNAs in your panel are expressed. Are they in showing up in osteoblasts, osteocytes, osteoclasts? Do you know where they're coming from?
Not yet. So part of the work that we're doing is going to help to differentiate that.
Thank you.
Can I follow up on that?
Mm.
I guess I'm really curious and interested about the fact that those microRNAs were best associated with the intracortical turnover, and I guess that made me wonder, how did you select those in the panel, and do you expect when you're looking at the in situ stuff that to see them more in the cortical bone?
Yeah. So when we chose that panel, we basically did a deep dive into the literature. We didn't want to do microRNA-seq in that pilot work just because we didn't have the funding. So we did a deep dive and we identified from the literature what were 4 of them, like the most promising biomarkers or microRNAs that we could identify, and then we just assayed them, and we got very lucky that they correlated with cortical bone. Now, the bigger project, of course, is to actually, repeat this, make sure that that was okay, and then do microRNA-seq to figure out everything else that we didn't look at.
Yep.
Great talk, Tom. Wondering if you could comment on the side differences between the tibia and the radius, and then furthermore, especially the radius is very distal on each side.
Mm-hmm.
To see better signals and have better sensitivity to axis.
So in terms of the differences between like the tibius and radius, I would be like, is it weight bearing? I mean, we don't really know. And then the second question I didn't hear.
So the distal side, that's the standard location of the scan picture. It's not very cortical side. So given you see predominantly cortical acid, looking at 30% or oxycycline will be better in general.
Yeah, I think so. Sure. So Annie's asking in terms of the cortical bone predilection for CKD patients, if the imaging for HRPQCT should be the distal site versus the proximal site. Did I interpret it? Is that what you said, basically? So, the data that I presented was from when we were using the XCT1, and that was all at that time we were using the standard site. Now, for all of our studies, we do both. We do a proximal and a distal site, and we do comparisons between when we do our cortical bone analyses. I think that the proximal site probably is better, but we're not definitively sure yet.
I should know the answer to this, but just with that in mind, is the proportion of bone which is cortical at the distal tibia similar to what it is at the distal radius? Clinically, I'm used to looking at the radius as the cortical site that it is for hyperparathyroid disease.
Right.
But I actually haven't
do not know the answer to that question. Andy, do you know?
Well, I mean, the radius is much more dynamic from the very distal end
Yeah.
of the scan to the proximal end of the scan. From the tibial, which is more homogeneous across, not the sinuous scan. So you go from almost all molecular site to I don't know, half and half site.
Yeah, but on average,
Yeah,
that's
an average maybe.
No, because whenever I talk about this, and and whenever I think about it, I think like you do at the radius. I always think, oh, the distal sites like, almost 90% cortical bone.
Yeah.
And I mean, the ego actually recommends like, hey, just check out the first half of your skin if you want to look at cortical bone.
Mm.
It makes sense to
Mhm.
just add all the error into your mission because it's not cortical bone.
So,
Does he say that though about radius and
Not
also
the tibia,
tibia?
not the tibia, the radius.
just the radius. Well, all of the bone GN scans have been done using, at least at the Columbia site, we've done both the standard site and so we've done the standard and the relative, and then we've done both the proximal and the distal. You could take a look at that.
If there was any skeletal site that would be, you think, most effective to study this in, as opposed to the sites we're limited to with nature?
Sure. So Andy asked if there was another skeletal site that we could study this best in, rather than the ones that we were limited to by HRPQCT. I mean, I guess you could look at the hip, at the femoral neck. I mean, HSA can give you some information on cortical bone. I guess you could do it with central QCT, if you had both spine and hip imaging. But nothing's going to give you the resolution of HRPQCT.
Well, I'm thinking about photon counting CT, which is coming up, and you can basically XT1 equivalent imaging with that. And it's a whole whole line scan. So it would be interesting to look at some other sites that might be more relevant.
Interesting.
And then for the hip, have you looked at 3D Shaper? That might be also an interesting.
So we tried to. So I've been chatting with Tom Wilson, who at 3D Shaper, and we have been impeded by. We had a change in the DEXA machine, and then all of those images went to storage. So I think the cohort that would be most useful for him or for this question would be the cohort that we recruited 15 years ago. That was our fracture non-fracture cohort. All of those were on this prior DEXA machine, and we are having trouble pulling them. I have other cohorts that I can give to him, but they're just not as interesting. This is something that we are interested in, though.
That's actually something else that I was wondering, and it's, you were going through your previous studies, how, I mean, I'm sure it depends on the question, of course, but I wonder how important you think it is to always discriminate those prevalent fracture CKD from CKD when you're looking at all these aspects of turnover, mineralization, volume. You're going to be in the studies that don't group them separately. Are we introducing a lot of noise in analysis?
With the fracture? I don't, so I think if you're looking at bone structure, you're not. The issue with the fracture, I think it becomes problematic when you're looking at the circulating biomarkers, because if they're recent fractures, then that will interfere with the data and introduce more heterogeneity. I think that with the microarchitecture, it might not produce as much of a problem. I mean, it'll be more severe phenotype of what's the already experience.
Yeah, they'll be one end of the other.
But I feel like you need that in a good clinical study, because that will give you the heterogeneity that you need to detect changes.
Right.
Okay, you're very welcome.
Any other questions here? Anyone else online? If not, we'll thank Tom.
Thank you.
Thanks.